Okay, Steve, so you've talked there about what goes on to actually pick up diabetes, to diagnose it in a patient. Can you talk us through the patient journey from that point onwards?
Obviously, once you establish diagnosis, it's a question of sharing it with the patient, so it's breaking the news, but it's also trying to start a plan with this patient of managing, and that may be addressing the particular needs of that patient. But from an organisational point of view, obviously you make the diagnosis, you want to get them in because you need to start looking at their cardiovascular risk, look at what their diabetes is actually doing, whether there's complications and the various issues associated with that. So once we make the diagnosis from an administrative point of view, we obviously got to put them on the diabetic register so that they then would be recalled. That then we can then monitor them and audit the care they receive. They would be invited to a practice diabetic clinic, which is where they have a full diabetic review. This is planned, and we do this over the course of a year, where once a fortnight we have a dedicated clinic where they come and see the nurse and the doctor and have the full range of the diabetic checks done. So we get them into that. Obviously there will be interim appointments with either a nurse or a doctor to manage the particular problems that may arise at the diagnosis. And also, the other thing too, of course, is that depending on what you identify, apart from the recall to us, you may want to involve other members of the team, whether it's in the community, whether you're looking at their feet with podiatry or dietetic issues with dietitian. There's diabetes specialist nurses which you may be wanting for specialist advice about treatment, or if they have diabetes complications, you may be obviously sending them in the direction of appropriate secondary care. But that the question is that you are recalling them. I mean, every month I would have a list of patients whose checks are due, and I review their records to see whether they do a check or not.
Okay,
so we have to keep tabs on them.
You mentioned a while back gestational diabetics. We've just got midwives accessing the course, so would the community midwife perhaps be another member of the team? Or?
Yes, the numbers would not be great, but obviously all women who are pregnant are screened for diabetes, because there are either pregnant women who are diabetic, who are known, and the midwives would be involved, and they would also, the hospitals would be much more involved, because you'd go to specialist clinics. There are also women who may develop diabetes during pregnancy, and that's increasingly happened. Midwives would be involved in that, but it is quite a specialised area, and secondary care is probably going to take the lead in that, because they are regarded as higher risk pregnancies.
Right, thank you, that's fine. The third phrase that you mentioned a minute ago was coronary heart disease risk factors, the risk profile. Can you tell me a bit about the importance of that in your eyes?
Particularly with diabetes, but in general I think it's extremely important. With diabetes, we know that particularly for type 2, people with type 2 diabetes, that 80% of them will eventually die of a cardiovascular problem. And so therefore, one of the focuses of your management of their diabetes is minimising their cardiovascular risk. It is, in a way, as important as managing their blood sugars and all the other issues you've got to deal with. So when you are seeing somebody with diabetes, you should bear in mind that they are at increased cardiovascular risk, and your interventions should be undertaken with that in mind.
And obviously diabetes is a chronic condition. Does that sort of throw up any particular challenges or perhaps even rewards for the doctor dealing with the diabetic patient?
Both. The challenges are because you have got many things that you have to keep your eye on. So therefore you are having to not just manage their symptoms today, but you're looking at what risks may be in the future for this patient, how they're going to do that. There's also a major educational issue, and rather than in an acute disease process where a patient is ill and they come in and they're sort of a little bit more passive, I'm ill, they come to the doctor, you give them treatment, they go away, they're hopefully better, and that's the end of that episode. So in this condition, because patients are actually having to make changes to their lifestyle and adjustments, managing their treatment, adjusting that accordingly, it's very much they are in control. They are the managers of the condition, and in a way the role of the healthcare professional is to empower the patient to feel confident to take that responsibility to manage their condition. Obviously things will go wrong, and help supporting them through that. It's a learning exercise. The rewards are that because you would develop a relationship with these people over long term, because you are supporting through a condition, you often have a much warmer long-term relationship with someone than if they're coming to see you as a one-off.
Yeah.
So, and obviously as you get to know them very well and you are advising them, they will have greater confidence in you. So, that's one of the rewards of general practice in the long-term relationships with patients. And if you ask most general practitioners, they find that one of the bonuses. So I think that diabetes can be very rewarding to look after. It's there's a lot of issues to tangle, but when it goes well, then it can be quite satisfying.
Thank you. You've talked a little bit about your practice, and I think we've got an idea about your practice population. The fact that you have got a high proportion of South Asian patients. Does that throw up any particular issues? Does it make diabetes a particularly pertinent issue for you here in your practice?
Yes, very much so. I mean, diabetes, as you know, is much commoner in non-white populations, and people who are of South Asian origin, it's going to be much commoner in that particular population. And again, because diabetes is associated with increased cardiovascular risk, and we know that South Asians are at increased risk of premature cardiovascular disease, it does actually throw up, it is extremely pertinent to our workload, because we're seeing more people in this particular group who are at higher risk, and so therefore it is something that you have to devote more of your attention to.
Right. Any particular ways that you need to adjust what you do to make sure that you cater for your South Asian patients who've got diabetes?
Yes, I think there are various ways in which you might have to adjust how you deliver the service. The first is that obviously communication is very important, so that if you are trying to convey messages, that you need to make sure that patients understand you, and that may be ensuring that you're investing in appropriate interpretation, so that you can convey the message, and also, as importantly, if not more so, understand what they're telling you. The second thing is that if you are looking at issues related to lifestyle, whether it's diet or physical activity, those adjustments need to be made in what people are comfortable and used to doing. And so often it's a question of saying to people not that you must stick to a rigid lifestyle or rigid diet, but that within the diet that you would eat, whether you make the appropriate choices. And you have to adjust that to your patient. Now, obviously, the cultural issues raise this, but also you could also argue that for any patient, it has to be the management program has to be tailored to what that person's preferences and needs are. With medications, sometimes you may have to be careful what medication you prescribe. For example, people who are Muslim would not obviously want anything that has pig-based derivatives. So there are things that you need to be aware of. Other issues may be to do with religious festivals. So, for example, again, Ramadan is very important for managing diabetes because and it's trying to help your patients to live their lives in a way that they feel comfortable with without being totally enslaved by the disease. It's trying to work around those issues and being aware of them.
So the cultural sensitivity is one of the sort of really important things you need to bring as a practitioner to diabetes care.
Yes.
This work was produced as part of the Tiger project and funded by JISC and the HEA in 2011. For further information, see www.northampton.ac.uk/tiger. This work by the Tiger project is licensed under a Creative Commons Attribution Non-Commercial Share-alike 3.0 unported license, based on a work at tiger.library.dmu.ac.uk. The Tiger project has sought to ensure content of the materials comply with the CC by NC SA license. Some material links to third-party sites and may use a different license. Please check before using. The Tiger project nor any of its partners endorse these sites and cannot be held responsible for their content. Any logos or trademarks in the resource are exclusive property of their owners, and their appearance is not an endorsement by the Tiger project.